Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is Tuesday, October 11th, 2022. Thanks so much for joining us on Facebook Live. As always, this is your chance to hear what's happening at Chicago Department of Public Health, get your questions answered. We will definitely give you some COVID update, but really today, because we are in budget season as a city, I'm really pleased to have a special guest. This is Fakurti Wagau. She is our long-term first deputy commissioner at the Chicago Department of Public Health. And as you can see, she has lots of binders with her, as do I, because this time of year we do a lot of work to really explain to City Council, explain to all of you how we spend money. And so our budget hearing at the Chicago Department of Public Health is scheduled for next Monday, the 17th. But we thought today we'd do just a little bit of a preview, give you a sense of some of the things that we're proposing in the budget, talk a little bit about dollars. And so Fakurti and I are coordinated this time of year. We didn't know we were both going to be wearing green. But Fakurti, why don't you go ahead and just introduce yourself, tell folks a little bit about your background, some of what you do at the health department, and some of the things you're thinking about as we head into budget season.
Sure. First, I'm glad to be here. Thank you for having me. As Dr. Arwady said, I serve as the first deputy commissioner. This will be my 6th year in that role, and it's really overseeing a lot of the administration and operations for the department. I've been with the department in one way or another for about 20 years. I started as a graduate student intern, became a health educator, and did a bunch of other things in between. Most of my career has been in HIV, STI, and a little bit in TB. So the administrative role is newer and interesting. I'm glad to be here.
Most definitely. So as always, we will start with a quick look at our COVID dashboard and then go through some slides, both about what's happening with COVID, as well as we've pulled together just some high-level things related to the CDPH portion of the budget. Then you'll have your chance to get your questions answered live. As always, you can use the hashtag AskDrArwady on either Facebook or Twitter, or put your questions directly into the blocks below. So let's start with the COVID data. As always, chi.gov/COVID- will pull up the COVID dashboard. And as you can see, things are continuing to look good from a COVID perspective here in Chicago. Everything, or almost everything, is green. We're averaging fewer than 300 cases a day diagnosed formally in laboratories and pharmacies at doctors' offices, and that has continued to go down. We still have about 22 Chicagoans every single day being hospitalized with COVID. So this is not over. We don't anticipate it being over. But deaths also, we're averaging less than 1 per day from COVID. Only about 1% of our emergency room visits and about 3% of our hospital beds are currently occupied with COVID patients. So the goal is to keep those hospitalization, deaths, emergency department hospital bed numbers as low as we possibly can, which is why we really need everybody over the age of 12 to be getting your updated COVID vaccine this fall. And you can see if we look at the vaccinations administered, remember, if you want to explore, you can always click and take a look. We saw a nice jump up in daily vaccinations here in Chicago when the bivalent booster, the updated vaccine, became available. You can see we were averaging 6,000 or so a day. That's starting to fall off a little bit, and we have a long way to go to get everybody boosted that we would like to. But overall, the news is good on the COVID front. I'm going to pull up just a little bit more data here. So first of all, Chicago does remain at a low COVID level. Happy to be seeing that. We are well below at both the city and the county level the cutoffs for case numbers, the cutoffs for hospital admissions, and the cutoffs for percentage of hospital beds. And so we would like to stay at that low level. At the low level, generally in most settings, that means masks are optional, although certain higher risk settings like healthcare continue to require them. We continue to put resources in where there are outbreaks. Nothing has changed in terms of isolation requirements. We went over all of this last week. So for time, we'll skip that, but happy to be at low. The other things that we also follow in Chicago are also all at low. So things like our emergency department encounters, our wastewater is looking good. The average score there is under 2, which is low concern. And we're at low risk for new variants, which makes me very happy. We are in good company. All of Illinois is now at low, as shown in green here, or medium COVID level, as shown in yellow. And last week, just 23% of U.S. counties were even high or medium. On the left there, you can see there's a few counties in orange that are still high risk. Those tend to be really localized outbreaks. Some more that are medium risk. Really, Appalachia continues to be the area that is coming down off a surge. But overall, we are in a good shape. Most important thing in low risk is staying up to date with your COVID vaccines, getting tested if you have symptoms. If you test positive, follow all isolation guidance, meaning you got to stay home for 5 days and wear a face mask days 6 through 10. Here's what's happening with variants. Good news overall, still all Omicron, still nearly all BA4 and 5. The green here, for those who follow along, is BA5. The blue is this BA4.6. You can see that BA4.6 is growing just a little, and we've got this BF7 now, that light green at the top emerging, about 5% of our subvariants. So right now, the Omicron vaccine, the updated vaccine, is targeted specifically toward the Omicron subvariant. So when you get your vaccine this fall, you, for the first time, are getting protection against everything in green, everything in blue, the huge majority of the variants that we're seeing. And that's new. That's different than anything that we had in the vaccines before. And so even if you got your last COVID booster and you're up to date, if you did not get one this fall, really, you should do that. Since the Omicron variant became dominant, I show these almost every week. The red is what are we seeing for infection rates in unvaccinated Chicagoans compared to in dark blue boosted Chicagoans. About 80% more likely to get infected with COVID if you're not vaccinated. You're almost 3 times as likely, almost 270% as likely to be hospitalized if you're unvaccinated in red here compared to boosted. And you're almost 6 times as likely to die if you're unvaccinated compared to being boosted. So nothing has changed here. Vaccines remain the most important thing. They're safe and effective. Bivalent booster update. So we are now over 144,000 of the updated boosters that have been administered to Chicagoans since approval. Last week we showed you the first 70,000 or so. So that's been nice to see that uptick. But if we look at the demographics here, the uptake of the updated vaccine is not where we need it to be. This is a chart showing by race, ethnicity, and then by age group, just for Chicagoans. What percentage of eligible Chicagoans, people who are due for that updated vaccine, and then how many have actually received it. So you can see white non-Latinx Chicagoans, 14.3% of eligible white Chicagoans have gotten that booster. About 9% of eligible Asian Chicagoans, about 5% of eligible Black Chicagoans, and about 4% of eligible Latinx Chicagoans. These all need to be 3 to 4 times what we're seeing even for the white Chicago number. So I'm concerned that especially in Latinx and Black communities, we're seeing lagging vaccine uptake, which means if we get a notable surge this winter, it's more likely to hit harder in those communities. But none of these numbers are where they should be. If we look by age, you can see that folks in their 70s are the most likely to have had that updated booster, which is good. But still, fewer than 1 in 5 eligible Chicagoans in their 70s have had that updated booster at about 17%. About 15% of those over 80 and about 12% of those between 60 and 69. So these numbers really, I worry a lot about this. These should be upwards of 80%. Ideally, they'd be 100%. And then as we go down, you see the numbers are not good. 12 to 17-year-olds, only 3% have had that updated vaccine. So there is still time. You can get the flu and COVID vaccines at the same time. Go to chi.gov/flu. This Saturday, for example, we are at Harry Truman College, 9 to 2. Walk-ins are welcome. People of all ages, 12 and up, can get the bivalent booster. You can get your first and second COVID vaccines. You can get your flu vaccine. Then on Sunday, we're going to be at Malcolm X, 9 to 2. These are just our large clinics. We also, I just took a couple screenshots just to give you a sense. If you go to chicago.gov/vax calendar, you can see all the places. We've got literally almost every day some kind of pop-up happening in different communities. We've got walk-in immunization clinics. These are regular locations where you can get free vaccine. So, and then of course we have our at-home program going, 312-746-4835. So plenty of opportunities. We've got City Hall clinics for City of Chicago employees coming up on October 13, as well as one in November and December. These are our upcoming bigger weekend clinics. And then again, chicago.gov/vax calendar if you want to go to something right near your home. I don't have an update yet on the timing for pediatric bivalent boosters. That's the updated vaccine for 5 to 11-year-olds. We do think we're going to hear news this week or possibly next week. So the FDA needs to authorize it. The CDC needs to sign off. My guess is that the earliest would be potentially next week or maybe the week after that we will have bivalent vaccines available for 5 to 11-year-olds. You will be the first to hear when those have been approved. But that means that we would have Pfizer for everybody 5 and up and Moderna for everybody 6 and up. As always, you have a question about COVID, you need a vaccine, you need a booster, or if you have a question about monkeypox, you can call us at 312-746-4835. All right, now we're going to turn our attention to the budget. So, Fakirti, you should feel free to chime in as we go through these, but we'll talk afterwards as well. So first of all, not a lot of people know what we spend money on at the health department. And we'll talk about this after, but most of our budget, like what percentage, Fakirti, of our budget comes from grants every year?
Every year during COVID?
every year the last couple of years, sure.
I would say about 90 to 95% during COVID.
Yes, exactly. A very small portion of our incoming money is actually from the city, what's called the corporate budget, meaning City of Chicago taxpayer dollars. Depending on the year, even before COVID, that was only, maybe 20% of our budget. It's been as low as 5% in recent years. I think this year that corporate city budget is about 7% overall of our entire budget, another 7% or so from bond, and then most of it comes from grants. And those grants are largely federal, meaning we can't decide how we spend them. They come with, here is money for HIV, here is money for tuberculosis, here is money for COVID. And so right now, our budget is a little bit lopsided with 60% of our money in what we call health protection. That includes millions, actually hundreds of millions of short-term COVID dollars that will not last. So this is a little unusual for us to have this much funding in health protection. Our other major bureaus, second largest in terms of dollars, is our Behavioral Health Bureau. And that's really something that's grown under Mayor Lightfoot. I'll show you in a minute how these break down. But by behavioral health, we mean our mental health work, our substance use work, and our violence prevention and intervention work. Next largest is what we call community health. Community health is about the health of communities. So this is where our environmental health protection work lives. This is where our community engagement, something we call Healthy Chicago Equity Zones, the community health workers that are going out, getting people connected to care. This is really where we think about the policies and systems and environments that make healthy communities. Next largest, at least right now, is what we call MICA, Maternal, Infant, Child, and Adolescent Health, at about 7% of our budget overall. Then next is what we call Syndemic infectious diseases. That is HIV, sexually transmitted infections, tuberculosis, and hepatitis. And then finally, administration, which is at only 3%. And I will just say, and please chime in here, the folks in our administration bureau, we don't have a lot of administrative capacity to support all of the rest of this work. So, Fakirti, please, chime in on this, but I think it's notable how little of our funding is actually on that administrative piece when you look at how much we're trying to get out.
I think that's right. We've seen significant increases there, though.
Yes,
even
we
though
have.
Proportionately, it's small, but it is not in line with the amount of administrative work that has come with the additional resources.
That's exactly right. So I'm going to just quickly go through within each of these buckets just to give you a high-level sense of sort of what we mean in each bucket. So health protection, which is the biggest bucket in yellow there, right now about 80% of that funding is for communicable disease. And by communicable disease, we mean COVID, we mean all of the outbreaks, whatever the outbreaks are communicable disease or disease control work. About 17% is in immunizations or vaccines. About just 2% is in our emergency preparedness, and that's been such an important area of growth and one of our strongest programs at the department. And then only about 1% right now is in food protection, which is all of the restaurant inspections, really keeping food healthy across the city. So that's our health protection. I wanted to highlight one additional investment that is in the corporate, meaning the city taxpayer budget in health protection, specifically in preparedness, given that that's an area of need. We have a proposal for about $2.5 million to expand our emergency preparedness storage capacity, our inventory management systems. I know a lot of people don't know what emergency preparedness is, but this is our bureau that, for example, the reason they need more storage capacity is when COVID hit, different than almost every other city, we had millions of pristine N95 masks for our hospitals. We had ventilators that could increase capacity. We keep medications, we keep PPE. Really proud of that work, but as the need has grown, we have more storage needs. Just to give you a quick sense of our emergency preparedness and healthcare preparedness teams, almost all of this was federal dollars. But in 2022, that team has, of course, led on city responses to COVID, to monkeypox, to both the Ukraine and the current South Central American migrant missions. We support in very direct ways citywide special events, thinking about health surges and health needs with the Pride Parade, Taste of Chicago, Lollapalooza, Air and Water Show, just the Chicago Marathon over the weekend. And starting now, there's Ebola screening that's going to be starting at O'Hare for Ugandan travelers and really thinking about preparedness around Ebola. So our emergency preparedness team does response, but they also do a lot of planning and exercises. So just in 2022, which has been the busiest year in decades for all of these simultaneous missions, we participated with Chicago Police Department in planning around a complex coordinated attack. What would that health response look like? We did Region 11, which means all of the hospitals across our city. A medical surge exercise. How do we communicate? We did an exercise at Union Station and with Amtrak around reunification. If there's some sort of, in a worst case scenario, a train derailment or some kind of mass transit of people, how do we make sure we can unify families and travelers again? We did some hazmat functional planning when there is a chemical spill of some kind, for example. The fire department goes in to make sure the fire's out and people are taken in, to the hospital, but the health department plays a significant role in how to clean that up in a way that is protective of human health and the environment. And then we've got ongoing planning for some bioterrorism preparedness called BioWatch. There's a national exercise coming this year. And then also just behind the scenes, we're looking to grow our Chicago Medical Reserve Corps. If you don't know, you can volunteer to be part of the Chicago Medical Reserve Corps. We love medical volunteers, doctors, nurses, respiratory therapists, but we also take non-medical volunteers who want to support the administrative work of, for example, standing up a large vaccination clinic. So just in 2022, thank you to the 434 medical volunteers and the 467 non-medical volunteers that supported vaccination and other efforts. You can get involved. We've got stuff on our website if you want to learn more. We love getting people into our Medical Reserve Corps. We're working to upgrade our ventilators. We're developing something called EM Track, which again, if there were to be a mass casualty of some kind, we want to be able to track patients or clients or event participants really using barcoded information and wristbands so you know where folks are going to the emergency department, how to support reunification. And then we continue to chair and support what's called the Chicago Healthcare Coalition. More than 500 healthcare agencies operate in Chicago, and at the health department, we coordinate that preparedness work. So the second section I wanted to talk about is community health. Remember, and if we look, you can see about 19% of our funding is in environmental health. About 28% is what we call our Healthy Chicago equity zones. And then about 53% is in our chronic disease work, our data work, our epidemiology. Just to highlight one thing in here, the Community Health Response Core. So this is something that we started with COVID-19 as the contact tracing core, where local organizations could hire and train navigators from the hardest hit communities to be a public health outreach, education, and resource workforce. So moving ahead, we want that kind of workforce, but not focused on COVID. And so you can see, one of the reasons we put the slide up is you see the way we kind of braid funding together. So we've got about $15 million from our immunizations grant, about $7 million from the American Rescue Plan grant, another $1.7 million from the health literacy grant, and then about $500,000 from the workforce development grant. This is a ton of work administratively, but it means that we can fund 19 community-based organizations, have more than 100 core members, and already with this new model, we've seen more than 10,000 people get resource coordination, things like getting connected to primary care, getting insurance, getting housing needs met through a health lens just between June and mid-October. And if you look here at the priority areas in pink here, these are the areas that we're the most focused on, and then in blue, the areas that experience economic hardship. And you can see these are the community-based organizations that we fund, where the dots are, and this is the list of them. And the idea is these are trusted community-based organizations where we want to think about incorporating connection to health resources, working on healthier systems environments. So that's one example of community health that we're really proud of, and that this short-term funding has gone to help us try to grow. The next bureau, our Syndemic Infectious Disease Bureau, you can see by far the largest bucket here is HIV, about 84%. Almost all of that is federal funding. I will tell you, and for Kurt, if you want to chime in, because this is your background, HIV is the only disease, I would say, that has been funded at anywhere near the level that it should be. And about 11% of our funding in this bureau goes to sexually transmitted infections, and then about 5% to tuberculosis and hepatitis together. Anything you want to say further about this bureau?
Yeah, I would say the level of funding and the longevity and stability of the funding have been critical.
Yeah.
And we just released a report last year about the lowest rate of new reported HIV infections, and I think that is very related to probably about 3 decades of stable and well-funded programming.
That's right. Yeah, just last week, if you didn't see it, the lowest number of new HIV cases since the 80s. And that wasn't just across the whole city. It was the lowest new number of HIV cases in all age groups, in all genders, in Black Chicagoans, white Chicagoans, Latinx Chicagoans, like really continuing to make excellent progress. But to your point, we've had sustained funding and we've been able to really grow important programs. In our Maternal, Infant, Child, and Adolescent Health Bureau, that's the one in light blue over on the left, about 7%, you see that about a little more than half goes to maternal infant health. And I wanted to highlight that this includes about $25 million that was part of the Chicago Recovery Plan to expand Family Connects. That's our goal to eventually have universal newborn nurse home visiting. So anybody who gives birth in the city of Chicago, there's a lot of evidence that having a nurse home visit to assess, mom's health, to assess infant's health, but also what other resources does the family need. So we've been growing there. About 38% of the funding in MICA is for lead and healthy homes. Lead paint remains by far the #1 way that kids in Chicago still get lead poisoning. Probably more than 95% of our lead poisoning cases are from lead paint. And so in 2022, there was about $47 million in the bond that lets us, for lower income Chicagoans, pay to abate that lead paint in homes over time. And that was a good investment. And then about 6% is in school health. We are proposing this year some new investments. This again is in the corporate budget, the city taxpayer budget, in reproductive health, and I thought I would just highlight those. There's about $2 million, an additional $1.5 million this year to support access to comprehensive reproductive health care in Chicago, recognizing that as other states are losing access to abortion care, that there is additional strain sort of on providers, on Chicagoans needing to access all kinds of reproductive health care. So that's a significant investment. But also, there's a little more than almost $550,000 to expand a program called CHAT. Chicago Healthy Adolescents and Teens. This is a long-term program of ours, and it's a program where CDPH funds in CPS high schools high-quality sexual health education and also free confidential STI testing. And we also fund condoms to be available at all schools. Right now, our CHAT program can only reach about 20% of CPS high schools. The idea here is an incremental investment that would maybe double our reach. We'd like to be able to provide high quality sexually transmitted infection education and testing in all CPS high schools, but we have a ways to go. And the reason is that if you look at the most recent sort of national survey that is done in schools, including CPS, about 31% of CPS high school students and about 11% of CPS middle school students say they've been sexually active. But among those who have been sexually active, only about 40%, so almost half, say they did not use a condom during last sexual intercourse. And that is, of course, a risk factor for STIs. It's a risk factor for pregnancy if it's between a male and a female. And so we really want to decrease stigma and have this be something that's universally available. And I put in a did you know here. CDPH already funds things like school-based vision program for optometrists or ophthalmologists to do eye exams and prescribe glasses for all students in CPS who need them. Totally free of cost. We do school-based oral health program, dental exams, cleaning, fluoride, and sealants, again, free. Both of these are completely free for all CPS students with parental consent. But unlike the sexual education and the CHAT program, those serve the entire district. And just given the increased attention on reproductive health, we think it's important to work on expanding our own programming. And then finally, there's about $375,000 proposed to expand what our own STI, sexually transmitted infection specialty clinics are able to do. We operate clinics that serve as a safety net for around 11,000 Chicagoans a year in Austin, in Lakeview, and in Roseland. And that would let us have some more staff and supplies to do more pregnancy options counseling, birth control prescribing, to meet needs for Chicagoans who are coming to the STI clinic. So this is an example of where we think it's important to shore up some of what we already do in this space, and it's something we're proposing. Anything you want to add on that? Okay. If we look at behavioral health has probably gotten the most attention outside of COVID for good reason. We've had big investments, both in terms of corporate city funding and American Rescue Plan, Chicago Rescue Plan funding. And so you can see right now that about half, 46% of our funding is in mental health. Only about 4% is in substance use. And that is not enough, honestly. We have a big problem with opioid overdoses. We know that there's a lot of prevention work and harm reduction work in substance use. So as there are going to be some opioid settlements that are coming in, and we're hoping to get some additional funding to support more of that work. But that's an area that really does need more funding over time. And now about half of that money in behavioral health is for violence prevention. That's everything from our violence intervention, street outreach work, to funding the Community Safety Coordination Center. So I thought I would just highlight, because we know there's a lot of interest in behavioral health, just to give you a quick sense of this. In mental health services specifically, if you go back to 2019, our budget was about $12 million in yellow there. We served 3,651 Chicagoans with that money for mental health, and 0 children. That is not enough in a city, obviously, of 2.7 million people. And so we've been really pleased with additional investments. By 2021, we were up to a $36 million investment in green. We'd increased 10 times. We were serving 36,000 Chicagoans with no-cost, high-quality mental health services, and we were up to about 7,600 children. And this year, with a total of $89 million, although that does include some ARP, CRP funds that would be used in subsequent years, we're on track to serve 60,000 Chicagoans on more than 14,000 children. So this is really an example of how investing not just once, but sort of over the years, lets us really build program. I'm very, very proud of the way we have scaled these mental health services, and I'm hopeful that City Council, also will be supportive as we continue to grow this work. This is quite small, but you can see it on our website as well. You can just get a sense of these dots on the left in 2019. These were the locations where we were either providing direct services or funding work outside of the walls of clinics. And then in 2022, on the right, these light blue dots, you get a sense we're just all over the city now. We will have locations that offer mental health services to everybody, regardless of income, insurance, inability to pay, in an actual network across 50 different organizations, and the goal is all 77 neighborhoods. So it's been an amazing increase. And I just want to thank all of our partners in what we call the Trauma-Informed Centers of Care Network. It's about $14 million a year, and that is a relatively small amount compared to the way we've been able to really together grow this access for safety net mental health services. You can check out mentalhealth.chicago.gov if you want to see more about it. I also just wanted to highlight quickly CARE. That's our Crisis Assistance Response and Engagement Program. About a year ago, for the first time in city history, the CARE program integrates behavioral health care professionals, mental health therapists, et cetera, to our 911 response system. It's a really big deal. It's not just about who's going out to calls, but we have mental health professionals now helping to staff in the 911 call center. We've created both what's called a co-responder team, where mental health professionals are going out with paramedics, with trained police officers to 911 calls with a behavioral health component, as well as what we call alternate response teams that don't have any police involvement, that involve a paramedic and a mental health professional. We can send that alternate response if, for example, we know that there is no weapon, we know that there is not a threat of violence, we know that there's not a crime in process. And then this year we're working to really build some more crisis stabilization. So if people have a crisis, are there places we can bring them besides the emergency department? So we've got a website, chi.gov/care. These are what the vans look like that the CARE team goes out in. We're looking to really expand this program further this year. I've been very pleased with the pilot. It's been a work across not just the health department, but the fire department, the police department, and OEMC, our 911 call takers. So we have a dashboard with data. In a year plus, we've had hundreds of responses. We've had no use of force and no arrests, and we're very pleased about that. Also, just quickly on substance use and overdose, again, more online, but I just wanted to highlight this. In 2020, more than 1,300 Chicagoans died of an opioid overdose, the highest ever recorded. We have more Chicagoans die every year from an opioid overdose than we do gun-related violence and car crashes combined. And there's a whole lot to do, whether it's distributing Narcan, which is the medication that reverses an overdose, to thinking about fentanyl test strips. And you can see on this map here, just since January 2022, we've been partnering with clinics and offices, mental health centers, and then recently Chicago Public Libraries. So on the right, this is our map across Chicago Public Libraries. We are rolling out the ability to have Narcan, that nasal spray that replaces, that saves someone's life after an overdose, will be at all libraries by the end of the year. And it's an example of, literally saving lives and getting the word out. And then we also just in this last year launched something called Medication-Assisted Recovery, or MAR, M-A-R Now treatment program. This is if somebody has an opioid use disorder and they decide they want treatment, not just, maybe they've had an overdose, maybe they've just decided now's the time. When people call the 24/7 Illinois helpline for opioids, we can now connect people same day even to that care. Since the launch of this, 82% of the people who have called seeking care, we have successfully connected them to same or next day opioid treatment. That's a huge deal. 93% have been connected to home initiation. 93% of people connected to home initiation of really the oral, the best medication for this successfully start treatment. And then 92% of them have been connected to long-term care. For those of you who know anything about substance use, these are remarkably high numbers. The program is going great. It began as a Chicago pilot, and on September 1st, the decision was made, it was going so well here, that it's going to be expanded statewide. So this is the kind of thing that we grow with additional investments and make a big difference. On street outreach, just on the violence prevention side quickly, this is really the work that has been successful in many other cities where we are funding. These are not city workers. We are funding organizations who hire individuals who know a lot about the current, whether it's gang or organized group debates that are happening right now on the street. Many folks who may have a history of incarceration or a history of being involved and now want to work on violence prevention. It's very dangerous and important work. I really want to thank the many agencies across the city that do this, and the city is really proud to fund this work. You can see going back, over the last decade or so, in some years we were able to put in a little bit of money. You can see 2016, 2017, 2018, $1 million, which for a city the size of Chicago is really not sufficient. But again, with Mayor Lightfoot coming in, with some of the American Rescue Plan dollars, et cetera, we've expanded that up to about $16 million this year just for this city street outreach. And it's a combination. We've got a lead agent model that can help support smaller organizations. We directly fund some organizations, and then we're doing some seed grants for some of the very small organizations that are hyper local and really working in some of the areas in Chicago that most drive violence. And you can see that in all of the areas shaded in blue now, the city now has real dollars for street outreach. And, we've gone from just 6 communities served in 2019 up to these 25 now this year. So this is the way, just to give you a sense of how we use our budget. All right, let's go ahead and take off the thing and get to your questions. So just to start off a little bit, while I'm pulling up the questions. So as you are kind of looking at this budget, what are you excited about? What are you worried about for CDPH?
I'm very excited about the new investments that you discussed in reproductive health, access, and education, as well as expanding our emergency preparedness program's ability to keep Chicago prepared for whatever comes next. I would say that's what I'm most excited about. I am, of course, excited about the continuing investments in the behavioral health lane that you also referenced. And our growth, smaller but important growth in our administrative capacities, also a little bit in our lead and healthy home capacities. Yeah,
we don't talk, the lead pipes, the water tend to get a lot of the attention, but really when you look at the data, the Chicago Department of Public Health, in case you don't know, we receive every single lead test that is done on a child for a Chicago resident. So whether you get it at a pediatrician's office, whether you get it at a WIC clinic, whether you get it at a screening site, every time a child is identified with an elevated blood lead level, our team at CDPH sort of jumps into action. We send out inspectors to figure out, how did this child get an elevated blood lead level? They're looking at the home. Is there, potentially peeling lead paint? They're testing the water. Is it related to water? They're looking to see, are there toys or spices or cookware even that sometimes can poison children, especially if those are things that weren't made in the U.S. And then we've got nurse case managers who follow those kids to make sure they're getting appropriate treatment and follow up and support. So, we've made enormous progress in lead poisoning levels in kids. And most of it has been due to working on lead paint. And I was really pleased to see the additional investments last year with the bond money, because when you can get rid of lead paint in a home, it's not just for those kids, it's for the kids who are coming next. All right, Deb Billow on Facebook says, across your budget portfolio, what is the area you think is the most underfunded? Interesting question. What do you think? We haven't discussed this, so I'll be curious to see what you think.
The most underfunded. It depends a little bit on how you look at it. I would say our tuberculosis program has chronically, not just in Chicago, but across the country, been underfunded. partly a victim of their own success. As you control a disease, money tends to go away, and we've done that well in Chicago. But in terms of absolute dollars, I think it's chronic disease.
Yeah.
It's the #1 driver of the racial life expectancy gap in Chicago. There's very little dedicated funding or, I think, good public understanding of what's needed in chronic disease control and prevention.
Yeah. We're very coordinated. I would have said tuberculosis every year, it tends to be, the aldermen will look at this and be like, why are we spending, it's not a large amount in terms of our budget, but why are we still spending on tuberculosis, where tuberculosis remains one of the top 2 killers in the entire world, like HIV and tuberculosis. We are in a very international, diseases do not respect boundaries. And you look 100 years ago, tuberculosis was the #1 thing that killed Chicagoans. And every year, people are still surprised to know this. There are many people diagnosed with active tuberculosis in Chicago. Tuberculosis is a treatable disease, but you have to take medication really daily for 6 months or 9 months or sometimes longer, depending. And so we have a whole team that supports people diagnosed with TB to make sure they are taking their medications. We house anybody who has tuberculosis or actually who has HIV and needs housing. We work to make sure that people are getting connected to care. Like, when things are going well, the tendency is to not fund. And I think, chronic disease never gets the love, even though it's what kills the most people, right? Even with COVID here, heart disease kills the most Chicagoans. And we often don't think about how do we create systems and policies and environments that allow people to be healthy. People don't realize, public health is not really fundamentally about the delivery of healthcare. We will do a little bit of that around the edges, but we coordinate with the Healthcare Coalition, for example. We work to make sure that where there are gaps and people are uninsured, they can get healthcare. But most of the work as public health is not you go to the doctor and you get care. It's actually the prevention of disease spread and the creating of environments that let people have access to healthy food and healthy streets and et cetera. So yeah, I would agree that those always are the most underfunded. But I would just say, if you were hearing, COVID has been funded well, but it's all going away. And the things that we have built during COVID are not things that the need for has gone away. And so my biggest worry is that as a country, the way we fund public health, Congress, because most of our funding is federal, Congress has to make the decision we're going to fund, and as opposed to actually funding at a reasonable, sustained level based on how many people live in Chicago, for example, or what are the risk factors. Instead, we pass these emergency packages for COVID, for Ebola, for SARS, for Zika, you name it. The health department gets an influx of funding, but it's very time limited. And so the problem is, when that funding comes in, I sometimes say it's like a deluge on parched earth, where we don't have the administrative capacity always to do what needs doing. And if you take COVID as an example, we've built amazing capacity to do wastewater surveillance. We've built really good capacity to test for variants. We have built all of this community health worker and Healthy Chicago Equity Zone work. We've grown our own ability to respond. We set up vaccines all over the city. We bring vaccines to your home. All of that is really threatened by the way we fund in this country, because when our COVID funding runs out in a couple of years, we've got, what does the funding cliff look like?
Well, there's a couple ways to answer that as well. About 86% of all of our money is through federal grants, and about 3/4 of that is COVID related. Right. So the vast majority of our funds will go away between now and, depending a little bit on how we bank on the money being stretched, through roughly 2025, 2026.
Yep. And in terms of us being able to start new programming with ARP, really 2024 is the end of that. And so it's this real challenge where I'm so proud of the work that we have grown in the infectious disease space, in the behavioral health space, in the maternal child space, like you name it. Some of those areas have gotten funding at a level they should have been funded all along for the first time. HIV, the only thing at the whole health department that has ever actually had anywhere near the funding that we need to set up what is needed. And COVID has given us this opportunity to sort of grow things that we want to do, but the worry is what happens more long term. And so, I'm really interested, people are asking, so what are you going to do about that? What's coming next? We are really trying to work, a lot of this is federal. It's about how do we fund health. In 2020, first year of the COVID pandemic, we spent more than $4 trillion on health in the United States. 5% of that went to public health in the first year of the pandemic, right? 95% of it went to all of the health care, and most of it should go to health care. But the work of public health, the work of safety nets and setting up the policies, the environments, 5% even in the first year of the pandemic. Okay.
I would add that's more than double the percentage that usually goes to public health.
That's right.
So we get just a small fraction of all the healthcare money.
Yep. All right. I see we've got some COVID questions. We've got some other things. I'll take a couple COVID questions, then we'll come back to some budget questions. So DS Shin on Facebook says, do any of these newer variants, this is on COVID, have the potential to be another Omicron like last winter? So variants are the $1 million question when it comes to this winter and to COVID. All of the subvariants that I showed you on that graph, whether it's the new 0.7, whether it's the BA 4.6, those are all still subvariants of Omicron. So that is good news in that even where we are seeing some continued evolution of the Omicron variant, it's all still in the Omicron family, which means that people who have had an Omicron infection would likely have at least some protection. And importantly, people who get the updated vaccine will have better protection against anything that continues to evolve in the Omicron space. The big question is, do we get another emergence of a variant that's very genetically different in the way Omicron was very genetically different? Delta was very genetically different. Alpha was very genetically different. We haven't had a big new genetically different variant emerge since really last December, January. It's been almost a year. And if you think about how bad last winter was, and then things have sort of calmed, that is as much about the fact that we didn't see a new variant as it is everything else. We've seen subtypes, et cetera. But the biggest worry is if people think COVID is over, they don't get their fall vaccine, they don't have the really strong protection against, because when you get the Omicron, when you get the updated vaccine, the idea is it's a vaccine that has been altered a little bit to help protect against all of the different ways that the virus itself has changed. So the spike has changed a little bit, and the vaccine makes your body more able to recognize the way the spike has changed, the way it attaches has changed. There's all of these actual genetic differences. And so if we don't get a lot of people to get this updated vaccine this fall, we are really set up in a not great way for the potential for a new variant. I am very hopeful we won't see one, but that really is the question. Every time there's another COVID infection, that is the opportunity for a new variant to potentially emerge. That's how they emerge. All right, let's do one more kind of flu and COVID question, and then we'll come back to some budget and we'll go back and forth. Ilya Valkovsky on Facebook says, what's the prediction for the timing and severity of the upcoming flu season? So once again, I don't have a crystal ball for sure. You can go to chicago.gov/flu if you want to see all kinds of data about what is happening with flu in Chicago. Every single week, we put out the most recent data about what are we seeing in emergency departments and outpatient settings, how many people are being admitted with influenza to the ICU, things like that. And our flu season has not really seriously started yet in Chicago, which is good. We are seeing some cases of flu. The most recent week, I think we had one Chicagoan admitted to an intensive care unit with influenza, just to kind of give you a sense of that. But less than 5% of people coming in are coming in with flu-like symptoms. But once it kicks off, usually we see flu seasons kick off sort of in the November to sometimes December timeframe, which is why we want people to get vaccinated in September, October, so the protection is there in time for the flu season. We look to the Southern Hemisphere as our best way to predict what this flu season will look like, because their seasons are opposite, and the Southern Hemisphere has had a very bad flu season during their winter, our summer. So they're just, Australia is coming off the worst flu season they've had in 5 years, with levels much higher than they've seen in either previous year. The other thing is that in the kids in Chicago, we are already seeing a big surge in respiratory viruses broadly. Even before flu has seriously kicked in, we're seeing our pediatric hospitals being quite full with kids getting admitted with RSV and other kind of childhood viruses, because for a couple of years, while people were masking and hand washing and being very careful because of COVID, we saw a lull in those other respiratory viruses. I very much think that lull is over. So I don't know for sure, but all signs point to this being quite a bad flu season. And my worry is if we had a bad flu season on top of a bad or even a routine at this point COVID season, that really has the potential to threaten our healthcare system. So I don't know, but getting your flu vaccine, everybody over the age of 6 months should get one every year. We make the flu vaccine to be protection against the variants of flu that are circulating. In the same way, we made an updated COVID vaccine to match the variants of COVID that are circulating. For me to worry less about COVID and flu as a city, for you to worry less as an individual, it's about you getting both of those vaccines this fall. Okay, some more budget questions. How has the breakdown of the CDPH budget changed over time, or at least over your career with CDPH? We're assuming COVID money won't last forever.
Before COVID, for a long time, hands down, HIV was the single disease that got the most funding, as we've alluded to earlier. Followed closely, not closely actually, followed by emergency preparedness, which I think typically had about half the funding of HIV. But emergency preparedness funding is really since the attacks of 9/11, so 2002 on. They are now smaller, much smaller parts of our public health funding portfolio, but I think as COVID funding drops off, that they will continue to lead our department in the amount of funding that we get.
Yep, I agree. A question here about CARE. That's the community, the crisis assistance response and engagement, the embedding mental health professionals in 911. James Beck on Facebook is asking, who makes the decision that it's a mental health situation? That is a great question. So one of the things that really makes CARE different is that it is a response to people who call 911. We have long had the ability to send mental health teams out if you call a mental health hotline. As 988 is launching, that's going to be, that's a national number that right now is sort of being implemented. If you call 988, you are calling because there's a mental health concern and you're looking for a mental health response. Chicago is the first jurisdiction in the state of Illinois to try a different response to 911 calls. And so 911 appropriately is very regulated. So the way this works is that if somebody calls 911, there are some questions that are being asked, not just, do you need police, do you need an ambulance, but depending sort of what you're saying, there are very routine questions that are being asked by the call takers. And if they meet the criteria for potential mental health involvement, they get coded as that. And then if they are in the districts where we are operating the pilot, CARE is not yet operating all over the city, we are then able to sort of send the CARE team. But I want to highlight that this is done by, a lot of people don't think about the call taker side of things, but the call taker side of things is actually almost the most central part to launching and building a successful program here. And because the state regulates 911, the state has to sign off every time we want to change the questions that the call takers are asking related to 911 call, as well as what kind of response is sent. And so we wanted to really build confidence, given that this is brand new. we were hearing a lot of, appropriately, concern from our partners in labor, the mental health professionals, the paramedics, about we want to make sure that our response here is safe, that we're protecting individuals. We also, the call takers themselves, there can still be a lot of stigma around mental health. And I think there are sometimes, the data doesn't necessarily bear it out, but there are concerns about potential violence. Our regulators wanted to make sure that the 911 response was sort of robust enough for the situation. And so, to give you a sense of this, at the very beginning, if someone called 911 and there was using this script deemed to be a mental health component, unless the caller could definitively say the person does not have a weapon and the person does not have any threat of violence, we weren't allowed to sort of send an alternate response team, for example. As we've shown that we can do this successfully and safely, from a regulatory standpoint, we've now, because what happened, a lot of the times when people calling, they're calling like because they see somebody across the street who is really pretty unregulated. They don't know if the person has a weapon. They don't know. So if it is unknown for a threat of violence, in some situations, we can now sort of send those mental health professionals. So that's just an example. The police also code any time that they are out on any kind of response if they perceive that there has been a mental health component to the response, and so does the Chicago Fire Department. So what we do behind the scenes is we look at the calls that come in. Do they appropriately get triaged using the protocols to the mental health team? And then on the back end, where else were we seeing calls that might have been appropriate for the care team but weren't coming in sort of through the triage? So that was a long answer, but it gives you a sense of behind the scenes why we're working across all 4 departments, why we're working with the regulators of 911, and how our goal, I would love to get to a point where mental health professionals could be part of every response that has a mental health component, but we're a long way from doing that yet. But I think it's critical. Sometimes people say, well, why do you even have police involved? The question is not whether police will be involved. The question is whether mental health professionals will be accompanying the police for some of these higher risk situations, if there is violence, if there is a gun, et cetera. And then separately, can we start to siphon off settings that don't require police? As 988 becomes more known, as other things become more known, that's not a problem. We can always send mental health teams there. It's the 911 piece. But we know 911 responses can go bad in a lot of ways, and especially if they have a mental health component. We want mental health professionals part of that care response team. Okay, one more question for you. This is a good one. Are we at the point where we'll be just going from crisis to crisis when it comes to public health emergencies? How does that affect the ability of agencies like CDPH to perform their everyday duties?
That is a good one. It does feel like we are going from crisis to crisis. I think the field of public health thinks that the key is sustained funding for core capabilities. We've lost workforce, less so in Chicago, but certainly across the country. About 20% of the public health workforce is gone since the recession of around 2008 and 2009. So I think it's building our workforce, building a pipeline for our workforce, training our workforce, and having sustained funding for really core activities like our epidemiologists who collect data and analyze it and share it, for program planning, for public awareness, et cetera.
Yeah, I think about sort of this crisis to crisis, for me, it's this funding problem that we only fund after the crisis has long since started. For monkeypox, you may not know this, the Chicago Department of Public Health has received exactly $0 for MPV response because at the national level, there has not been the political will to do emergency funding for monkeypox. We also, because of the way funding comes, we are not allowed to use unspent COVID dollars to do monkeypox response or to do Ebola preparedness or to do, a foodborne outbreak. This very disease-specific funding is pretty unusual to public health. It's not how we fund most other things. And it's our biggest barrier, I think, to sort of long-term success. The ability of agencies to perform their everyday duties. What I want is the ability to, for example, fund a workforce that every single day is out in communities, you know, working on diabetes, linking people to healthcare, like doing that chronic disease work, which is never funded appropriately, but that we exercise and train those folks, and that same workforce pivots during, you know, flu and COVID vaccine season to focus on that. If there's some emergency, we pivot to be able to move those resources. Right now, the way our funding comes, if someone is funded, and we're about 86% grant funded, if you are funded on a grant that is for hepatitis, officially, you are not allowed to work on other diseases, really. And that makes it very challenging for us. And so I'm really hopeful that we will move as a country. Like, the biggest lesson for COVID for me is stop doing this deluge and drought. It's about, how do we think about sustaining preparedness? How do we think about the staff, the stuff, the programs that is disease agnostic, works on public health all the time, is measurable, reportable, but it really, you know, that has to change for us to be successful as a department. And that's true in every single part of our response. We are just about at time. I'm going to just quickly, Alexandria Deanne on Facebook says, I'm seeing a lot of news about BA.5 variant dropping, these other ones starting to grow. Is this not concerning heading into the holiday season? I'm feeling deja vu from last winter. So again, I would say anytime I see shifts in variants, I'm a little concerned, but the reason we are still low risk, and that's why we do that low, medium, and high risk for variants, is because everything is still Omicron. So as long as people get their vaccines, I haven't seen anything really scary yet on the horizon, but I do think we're going to see a COVID surge. I would be the happiest person alive if we get to February or March and we haven't seen even a small COVID surge, just because it's respiratory season. And the way that we see flu and RSV and everything else surge in the winter, I think we're expecting at least some COVID surge. The question is really, what does that look like with variants? What does that look like with people being as protected as they can be? And then Francie Swidler from Facebook, we are going to take your question next week. She says, I saw a report that a cancer-causing weed killer is being sprayed on produce at a high exposure here in Illinois. What kind of risk comes from that? Should I be worried? The reason we will take your question next week is that next week, at the request of folks who have written in, we are going to be focusing Facebook Live, you know, in addition to our regular COVID updates, we're going to be actually focused on our environmental work. So that's a good opportunity. We'll take that one, but also explain a little bit more to you about what the department does on environmental health and protection, how that fits into some of what is happening across the city, some of the things we're growing on, and take your questions. So we will be addressing that because it's an environment question next week, and I'll have a guest or two on with that being the focus. Thank you so much for joining us. Again, if you missed the intro at the beginning, this is for Curdy Wagau. She's our first deputy commissioner at the health department, which means she really leads all things about administration, from funding to all the behind the scenes things for IT and legal, our human resources work, our compliance work, all of the work that lets us focus on the more programmatic facing sides. And if you want to hear a lot more about the CDPH budget, you can watch our budget hearing, which will be streamed next Monday. We are the third department up, meaning it will start at some point in the afternoon. You'll see for Curdy and I, as well as Mary Emanuel, who is our director of finance, sort of up answering questions from the aldermen about budgets. But I appreciate your attention and your interest. Good questions. The budget hearing streams at ChiCityClerk.com. So every day, if you're interested in city government, go to ChiCityClerk.com and you can see different departments explaining their budget. Anything you want to just say in closing for folks to be aware of heading into budget, or anything else?
I think the only thing I would add is that really most of our funding comes from the Centers of Disease Control and Prevention, and what we're feeling here is really a reflection of the money that that agency receives from Congress. They've received flat or reduced funding.
That's right.
with the exception of emergency money, and that just trickles on down to the states and the counties and the cities. And I think if things don't change there, they can't change here.
Yeah, that's exactly right. Different than almost every, the Chicago Police Department, the Chicago Fire Department are almost entirely funded by sort of city taxpayer dollars, that corporate budget. Only this year, 7% of our money is from those city taxpayer dollars. Most of the rest of it is coming, as you said, the bulk from CDC. We also get a little bit from HUD, Housing and Urban Development. There's a few others, but I think that's a good flag that as CDC is not getting the support it needs, don't think of that as a federal problem that doesn't affect us. When the CDC is not funded, CDPH is not funded. And all of us really in public health, there is just a lot of need. There's a lot of systems and a lot of need for funding. And I hope, you've learned probably, I imagine, a fair bit about what CDPH can and does do over the last couple of years because we've been much more kind of in the spotlight for COVID. But this is the important work we do every day, year round. And we want Congress to fund public health, not in a disease-specific way, but fund the CDC, in those big buckets, for example, like I described to you, for maternal, infant, child, and adolescent health with some very general work across that, funded in disease control, funded in emergency preparedness, but not 35 different funding lines for COVID that you can't use across. Administratively, it's a pain. And more importantly, on the ground, it means we can't always do what Chicago needs. Thank you so much for your attention. We will be back next Tuesday, October 18, at our regular time with a focus on environment. And in the meantime, be well.